All right, my name's Ed Liu. I'm from Colorado, the Children's Hospital, Colorado. And so I'll just start off. I'm going to give you the pediatric perspective and kind of what I think you should know about pediatric celiac disease. It's certainly a public health problem. I think we should think about this as a public health problem, and it's commonly quoted to affect adults like 1% of the time. But in other countries, like in Finland and Sweden, in adolescents, they're finding that it's as prevalent as 2 to 3% in their population. And the problem is, like, clinical detection is really difficult, right? I mean, over half of all the cases of celiac disease are actually subclinical or asymptomatic. They're kind of silent, right? As Dan said, it's estimated that we're only diagnosing about 25% of all the cases. So how common is it, though? Well, we have a study in Denver looking at the general population, and these are estimates, but we think that it actually may affect up to 2 to 3% of the population. And this is through one of these large, one of these cohort studies from birth where we follow children in Colorado who have a genetic risk for celiac disease. And looking at the incidence, we see that there's actually a pretty rapid development of celiac disease within the first 5 years of life. And it goes on to 10 years of life. But then after this, we're not seeing a whole lot of new cases. So it doesn't mean that people after age 10 never develop celiac disease. We know that's not true. But as Dan said, I think that the majority of cases, if this estimate of 2 to 3% is true, then majority of cases probably occur in childhood. And celiac disease isn't the only thing, though. There's a lot of other conditions that are on the rise over the decades. This includes other autoimmune diseases, inflammatory diseases, and allergic conditions, right? This is not just in the United States, but also in countries in Europe. There's a lot of hypotheses as to why this may occur, but since the genetics really aren't changing that much, we think that it's really due to changes in the environment. We don't know exactly what it is, though, right? So how are we going to catch all these cases? As it stands, there's recommendations to screen for celiac disease in individuals who have a risk, right? And this is sort of according to NASPGHAN, the North American Pediatric Society for Gastroenterology, Hepatology, Nutrition, that individuals with type 1 diabetes and autoimmune thyroid disease, autoimmune liver disease, juvenile chronic arthritis, Down syndrome, Turner syndrome, and including first-degree relatives with celiac disease, right? These are the individuals where we should be screening for celiac disease. Now, the problem is, most cases of celiac disease occur in the world actually don't fall into one of these risk categories, right? And remember, if you're just looking for individuals who have symptoms, probably about half of all cases are actually asymptomatic. So this makes detection very, very difficult. So if you look, though, at the genes that put you at risk for celiac disease, like the major genes for celiac disease are what we call HLA-DQ2 and DQ8, right? And DQ2 is really the big celiac risk gene. And keep in mind that if you don't have one of those two genes, then your chances of getting celiac disease are very low. It's not impossible, but very low. The thing is, 40% of the population actually has these genes, okay? Whether it's having 2 copies of DQ2, for example, you inherit 1 copy from mom, 1 copy from dad, or like DQ8 or a combination of DQ2 or DQ8. So 40% of the population actually has a risk for celiac disease. Now, it doesn't mean everybody who has the genes are going to go and develop celiac disease, but it means that there's a risk. And again, without those genes, then your risk is very, very small. And through 2 studies, one is called DAISY, one is called TEDDY. These are long-term prospective birth cohorts following individuals who have these particular genes. We actually have information on the risk of celiac disease by looking at what we call HLA genotypes, or these genes, right? So if you have 2 copies of DQ2, your risk is about 15% over the first 10 years of life of developing celiac disease. If you have 1 copy of DQ2, which is actually the most common type of gene combination, is just having 1 copy of DQ2, your risk is about 10%. If you have the smaller gene, but you have 2 copies of the DQ8, risk is about 5%. And if you just have 1 of those copies of DQ8, then your risk is about 1%. So we're starting to get some information as to what the risk is of developing celiac disease in childhood, just based on these simple gene tests. Now, this is data from TEDI. Okay, TEDI stands for the Environmental Determinants of Diabetes in the Young. And so this is a large multi-center birth cohort study. It involves a center in Sweden, Finland, Germany, and then 3 sites in the United States, in Washington State, Colorado, and in Georgia. And so we're following thousands of kids who have the genes that put them at risk for celiac disease, and we test them very, very frequently throughout childhood for the development of diabetes autoantibodies, and also for the development of celiac disease antibodies. Okay, along the way, like no one's born with celiac disease, right? You just have the genes that put you at risk. But we basically put these kids in this cohort under a microscope. So we're looking at every factor, such as what medicines did you take, when did you start eating gluten, how much gluten were you eating, what did you do in terms of nursing, what infections did you have, and all these things. And then we look back, and so we're starting to see children start to develop celiac disease, and diabetes, right? And then when they do develop disease, then you can go back and look at all this epidemiological information to kind of try to look at what the triggers were that may have led to the development of disease. Now, I'll say that this is originally a diabetes study, right? Hence the name TEDI. But I'll tell you that celiac disease, the celiac disease outcomes really, really overwhelms everything else. I mean, we see more cases of celiac disease in this diabetes study than they do diabetes, right? So this is just a plug-in that means we should actually be doing a study like this for celiac disease and maybe piggyback diabetes the other way around. So these are all the factors, for example, that we look at, right? Environmental factors in terms of gluten intake and the season of birth, what was the mode of delivery, were you taking antibiotics or probiotics and infections. And so this is what the TEDI study has been doing over the past 15 years, right? Looking at all these environmental triggers. And so we start with the genes, and then we look at these potential triggering events. And it turns out that the major factors here, okay, after all this research, is that the major factors are probably going to turn out to be gluten, okay, like diet factors, and infection factors. So you got genes, you got diet, meaning gluten, and you have infections, right? And so this is sort of what we have now in TEDI, right? So the red ones tell you like which ones are associated with risk. These are the factors that we know do increase your risk, okay, to some degree. Now, we have to keep this in mind that the perspective is very different. It's not like these are absolute, but these are things that do bump up your risk, right? And then the other ones, X dot, mean we've actually disproved those hypotheses. And so this is sort of where TEDI is now, and we're in the process of writing a review of all the findings now that these kids are becoming 15 and they're aging out of the study. So more to come on this, but this is just to give you a flavor of what the potential is with large research funding. So in terms of disease onset, I think in pediatrics, we're kind of in a unique position because we can start now to identify children who have like an extreme genetic risk. So we're able to start to predict risk for these kids. And we're also starting to develop a better idea about these environmental risk factors, right? I mean, we don't have, we know that gluten plays a role, okay? We know infections plays a role, but how are you actually going to impact that, right? I mean, we don't have enough information to be able to change like feeding recommendations or recommendations about, infections, vaccinations. But this is a start. And I think the thing is, at some point, it's going to be unacceptable to simply watch these kids who are at risk of developing disease and do nothing, right? And so I think this is really an opportunity to start to study disease prevention. So how do we prevent disease from occurring? Well, I mean, this is the problem, right? So here's what we call like a survival curve. And now the top line are those who have 2 copies of DQ2. Now, having 2 copies of DQ2s, not that common. Only 1% of the population actually has this highest gene risk combination. The most common one is being DQ2 heterozygous, meaning you have 1 copy. But it's tough to watch these kids who have a genetic risk go on to develop antibodies and then go on to get diagnosed with celiac disease. And yet we have nothing to offer them right now in terms of prevention or disease interception. So I think that, what did I write here? Oh yeah, we need to focus on like disease prevention and interception. I mean, that's going to be another thing that's going to be a target in the future. So much of what we've learned from what I've shown you is really this kind of research is done in association with type 1 diabetes work, right? And the reason why we piggyback celiac disease onto research in type 1 diabetes is because, frankly, the funding mechanisms in diabetes is so much better, right? We just don't have anything for celiac disease. Now, it's also because the major risk genes for diabetes are shared with celiac disease. And so typically we think of this as an autoimmune triad: type 1 diabetes, autoimmune thyroid disease, and celiac disease. So these things can occur all together. So it makes sense to try to batch this research all together. So this is a graph showing you like what kind of studies in the past and present are going on now. These are celiac disease and type 1 diabetes prospective birth cohort studies. So looking at kids from birth and then following them. And you know, let me show you that these ones here circled, all of these studies, these large ones, with the exception of Generation R, are really diabetes-based studies, okay? And the smaller ones on the bottom are like celiac disease-based studies, okay? So again, this is really emphasized that this is all driven by type 1 diabetes at this point. So, you know, there is also another study that we're doing in Colorado called ASK, and this stands for Autoimmunity Screening for Kids. And basically, this is testing out the feasibility of mass screening in pediatrics. So we're offering free screening for celiac disease and type 1 diabetes in all children from ages 1 to 17. And to date, we've got 30,000 kids screened. We're aiming for 50,000. And what it's showing is that, you know, when we do mass screening, right now we're finding that 2.4% of all kids tested are initially antibody positive, the tissue transglutaminase antibody positive testing, but then we invite them to come back for confirmation. And right now our confirmation rate is such that we're seeing about a positive rate about 1.9% of the population of children who have antibodies for celiac disease. Remember, not everybody who has antibodies are going to actually go on to develop celiac disease, but these are individuals who persistently have antibodies. And this is excluding all the kids that we've already diagnosed in Colorado. So the number, it turns out, you know, we estimate that the Colorado population of adolescents probably have, you know, roughly a prevalence of about 2 to 3%. It looks like it's probably turning out to be real. And what we're seeing right now is, again, symptoms is not a predictor of antibody positivity. So you can't rely on symptoms. So if someone says, no, you look too well to have celiac disease, it just doesn't matter because individuals can be asymptomatic, okay? And I think the bottom line here is that without mass screening, the majority of cases are actually going to be missed, right? I mean, if you want to try to catch all the cases, you can't rely on symptoms, you can't rely on being in a risk group, right? You really need to screen everybody. Another plug-in here is that what we're finding now is that children with celiac disease actually have a lower health-related quality of life in the United States. So there's been a lot of studies from other countries that report that the quality of life in children with celiac disease are really no different from others without celiac disease, except one study that was published in Ohio that suggests that, you know what, in the United States, children actually have a lower quality of life. And we've got another study now that's been submitted that really confirms this in Colorado. So it may be that in the United States, the quality of life for kids with celiac disease is actually lower, even though it may be higher in other countries, right? In addition to that, looking at the families and caregivers who have of children with celiac disease, you know, the families also have a lower quality of life compared to like individuals without celiac disease, and even compared to individuals with a child who has another condition called eosinophilic esophagitis. And this is also a disease that affects your gut, and it can be managed by diet, but the option is you can also be managed by medications. So, you know, one of the questions is like, why is it lower in the United States compared to other countries, right? And I think this really certainly does emphasize the need for psychology coverage as part of routine celiac disease care. Dietitians, necessary, okay? But the problem is it's not always a covered benefit in celiac disease. We know that the gluten-free diet's a cornerstone for treatment, right? And in both the pediatric and adult guidelines, it's recommended that there's dietitian support for the gluten-free diet, whether it's in education or for help in monitoring. Now, the medical nutrition therapy coverage by Medicare will cover dietitian visits for individuals who have diabetes and kidney disease, but it doesn't include celiac disease. Okay, so that's a major problem. Celiac disease is not a covered benefit. And for, sorry, I meant to say Medicaid. Medicaid coverage varies by state. All right, and so this is a major problem because we also know that private payers don't always cover dietitian visits. Okay, so the thought is that if we can start to push for Medicare, Medicaid coverage for dietitian visits, hopefully the other insurance providers will follow suit. So what's the path forward? You know, in my mind, you know, we certainly need to treat this like a public health problem. We need to continue to push awareness and knowledge about celiac disease. We have to start to understand the reasons why the quality of life is so low in pediatric celiac disease in the US compared to other countries. What are we doing wrong? How can we improve this? And you know, how would this change once medications are available? I think we need to improve our case finding, whether it's by developing smarter screening or testing strategies. Should we consider mass screening? There's some potential benefits, but also like some potential downsides to doing mass screening. And so that needs to be considered carefully. You know, funding, I think, is really needed for these longitudinal multi-center studies. You know, we need to show that we can collaborate, right? These kind of studies, like what Teddy does in diabetes, is what we need to do in celiac disease. And we need to invite those diabetes folks who've got that experience to work with us, so we do celiac disease and they piggyback on diabetes. And you know, I think we're going to need to really develop the infrastructure for the early diagnosis of celiac disease, and also develop the infrastructure so that we can start to prepare for strategies for prevention and disease interception. Now, more immediately though is, again, I told you, it's standard of care for patients to see dietitians to help them manage their celiac disease. There are no other options. It should be a covered benefit. That's going to be a push that I think we should make in the future too.